Thank you so much, ma'am. And very quickly, I will speak about the other reasons also, but essentially, I think what I had understood was that individualized prescription with regards to hormonal treatment. So, when we look at medical management for male subfertility, and if we start breaking it down into why we want to use something and when we want to use something, there is some theory behind it, and we'll try to discuss and try to understand how this is based or what this is based on. When we talk about medical therapy, it is either evidence based, which means we use specific medical therapy, or we use empirical medical therapy. When we talk about evidence based, which means for which solid, strong evidence is available, it's only available for hypogonadotropic hypogonadism. For no other treatment in the form of either hormonal treatment or antioxidant treatment, is it a specific therapy? Yes, there is another group of treatments which are medical, though we don't call them hormone specific treatments. That's for the infections of the genital tract and MAGI, as we call them, the male associated genital infections. And those are also treated by specific medication, but I'll not keep that into the purview of this because otherwise this becomes an unending talk. So if we talk about idiopathic infertility, if we talk about eugonadotropic or hypergonadotropic hypogonadism, if we talk about other reasons for which we may use therapy, all of them become empirical. Now, when we talk about hypo, we know that this may be congenital or acquired, and very common these days. You'll find these men. In fact, this may be a question from a lot of practitioners if they've been using gym supplements, if they've been using steroids, opioids, or there's been testosterone use. So. Time and again, we find couples coming in where the man says, I have this need for my particular physical appearance. I'm a model or I'm whatever, and I need to take supplements. So please guide me as to how I can go about with that also as a profession. And then if I seek fertility, how and when should I approach you, or when should I approach the fertility expert, and how should I go about it? And you have to be aware of this. So it's not all right to say that you just can't take it at all. We know it's detrimental to fertility, but we also know that there's a protocol that can be followed to somehow safeguard fertility when desired. And then obviously those that have pituitary tumors, and then secondary hyperprolactinemia and the resulting subfertility. So, if we were to look at men that came in with hypogonadotropic hypogonadism, the ideal treatment preferably would have been a pulsatile gonadotropin releasing hormone therapy, which is in our country not, in fact, in a lot of countries not available easily, and that's not a therapy that we use. So, what is the therapy that we use? Now, the broad line therapy that we use is gonadotropins, which means we use HCG or recombinant HCG. These days, I have a preference to using recombinant HCG, and that's recombinant LH, sorry, and or look for a response. See the clinical biochemical response. So you have three groups: one in which you would have started the HCG straight away, one in which you would start with HCG and HMG straight away, and the third where you would add HMG later. In fact, a fourth group where you could pre-optimize with the recombinant FSH and then or the HMG and then add HCG later. And I'll tell you when that differentiation has to happen. So in most groups, the ideal therapy is that you can start with HCG and HMG together. If you were to compare this group with where you've added HMG 6 to 12 weeks later, the difference is little, though whatever difference there is, it favors the outcomes that where HCG and HMG have been started together. You look for a clinical and a biochemical response. What do you mean by a clinical and a biochemical response? You want to see at least twice the increase in size of volume of the testes, and then you monitor the response of testosterone and secondary sexual characters. And as you see that, then this is a longer term therapy. And in most men, you may be able to retrieve sperms beginning 6 months to 12 months. and may find sperms in the ejaculate from 12 months to 3 to 4 years. And so it's a long-term therapy, and these men have to be counseled. But you get a lot of these men much earlier, and if they are willing to initiate these therapy before they've actually gotten married, they've gotten into this idea that they want to see whether they are able to get their fertility, then you're able to give them long-term therapy. We've had a fair number of men that have come in before they've actually had marriage, but they've had the idea that they would like to stimulate themselves, see the presence of sperms in the ejaculate. You may even freeze them and then proceed thereafter. So we monitor testicular volume, the trough total testosterone, semen, which means mid-cycle and just before the next dose, and sperm in ejaculate usually between 6 and 36 months. Now, what do you do if the hypogonadism is to the level where the testes has not been fully stimulated yet, which means this is a patient that is previously untreated and has a small volume testes. For him, if you were to initiate an HCG therapy straight away, you would limit the possibility of spermatogenesis, because here there is still certainly cell maturation that is to be completed, to be achieved. And in such patients, you would want to pre-treat with HMG or recombinant FSH. Now, this is the group of hypo that you would treat. What are the other indications that you have? Now, if you were to have empirical therapy for a young group, we're all aware of this in terms of using them for 3 months in most patients. Then depending on how the couple has come into you, if it's a young couple, you may proceed from 6 to 12 months. If it's an older couple, you probably give them this 3 months to have them accept the fact that they've got to get into ART as soon as possible. Now, sorry. Yeah. And this is the form of empirical medical therapy that you may use. Again, here also, when you use hormones to stimulate any spermatogenesis that you may think is stimulated from here for quality or quantity of sperm, this is a form of empirical treatment, use of hormonal therapy as empirical treatment. And there are certain rules to that also that you will follow. They're not done without those rules. Now, the rationale for using hormonal optimization for either OATS or NOA is to increase the levels of intratesticular testosterone. This increased intratesticular testosterone will stimulate the spermatogonial DNA synthesis, spermatogenesis, will result in well-differentiated seminiferous tubules that may be detected during sperm retrieval. So if you're looking at severe OATS or NOA and you want to stimulate, that's the reason why you would be stimulating. The second thing is, what can you use for pre-retrieval optimization? So as has been seen, they've used anti-estrogens, they've used aromatase inhibitors and gonadotropins. And there's been some evidence of using clomiphene even as empirical therapy for idiopathic male infertility. So before that, let's look at anti-estrogens, whether you want to use them as pre-treatment or whether you want to use them as empirical therapy. So we know, again, clomiphene, non-steroidal estrogen receptor blocker, has mild estrogenic effect. What is the dose? The dose is a little confusing. Previously, we used to have this 25 5-day cycle, then we moved to 25 milligrams per day. But at some times, you will stimulate more than 25 milligrams per day. And we've seen in some men, particularly if they're not responding to the standard dose of clomiphene stimulation, you may use a higher dose. If they're still eugonadotropic, if they've got their total testosterone in a low range. Tamoxifen has also been used. Again, we'll not go through this hormonal cycle, but I'll just explain the rationale for using these agents. Now, you've understood for clomiphene, but what about aromatase inhibitors? These are used in increasing tendency now. My preference is to use anastrozole. You may use anastrozole or letrozole. And we know that if you have excessive estradiol, this is going to suppress FSH and LH, inhibiting testosterone biosynthesis. And hence, you've got to block the aromatase here and improve the testosterone estradiol ratio. So wherever you find that the TE ratio, normally which is 10:1, here you've got to reduce the estradiol in the peripheral circulation, and the aromatase inhibitors inhibit this conversion and allow the TE ratio to be reversed back to the normal 10:1 ratio. This is commonly seen in obese men. It's also seen in men with Klinefelters who may not be obese. In fact, if you look at some studies for Klinefelter where they've had good success with retrieval of sperm following pre-retrieval optimization, there's one study which stands out where aromatics or anastrozole was used, and it resulted in a increase in the sperm retrieval rates in men with Klinefelters. So particularly for Klinefelters, you'll find this to be useful. Now, if you were to see the medical therapy that's been used over the years in a lot of men that have either idiopathic NOA or have shown maturation arrest or have hypospermatogenesis or Klinefelters, the basic groups that have been used, the basic studies that have been used have veered between use of recombinant or gonadotropins, urinary gonadotropins, versus agents such as clomiphene and anastrozole. This is the paper that I was talking about where successful fertility treatment for Klinefelters was done using aromatase inhibitors. And they also had another group where they used HCG or clomiphene, particularly where they did not get a response with the aromatase inhibitor, and then found really this, though we've never found sperm retrieval rates as high as those exceeding 60%, but we've usually had our retrieval rates, even with pre-retrieval optimization, between 25, 30 to 40% for men with Klinefelters. There's also a group of men where high dose HCG will work. There's this Japanese study where thrice a week 5,000 units of high dose gonadotropin has been used to great success, where outcomes of the second microTSA resulted in more retrieval. So if you were to form a basis of when would you choose to use gonadotropins in men either with OATS or those that are azoospermic, how would you form your guidelines? Now, the hormones that you would have to study would be FSH, LH, total testosterone, and estradiol. If you were to find that they are eugonadotropic, which means the FSH and LH, now usually again varying on labs, but we'll consider anything below 5 to 6 to be normal, and a eugonadotropic male to be someone that is got a level below this. And in such a male, a level of testosterone being less than 400 and a TA ratio being normal, the clomiphene dose of 25 to 50 milligrams per day may be used. If the TE ratio is reversed, then anastrozole in the dose of 1 milligram twice or thrice a week may be used. Now, what is the problem with using a higher dose of clomiphene or a higher dose of anastrozole, particularly in men? We've seen libido is affected particularly. And if the libido is affected severely, then we'll find that they will not be attempting too much. If you're looking at OATS and natural pregnancies being attempted at, then that may be a challenge. Now, if these are men that are in any case going to go in for sperm retrieval, that means non-obstructive azoospermic, then increasing the dose will not make a difference here, because in any case, they're going to go in for a sperm retrieval procedure. Now, that's for men that are with OATS. When you come in with non-obstructive azoospermia, we tend to be more aggressive in our approach. And in these men that are eugonadotropic, we will tend to use gonadotropins. My preference now is to use recombinant LH and FSH, and we can begin with both of these and give a short-term course of 3 months and up to a maximum dose course of 6 months. And usually, again, we want to begin this if the total testosterone is less than 400 and keep a target testosterone of 600 to be our upper range of target testosterone, which will monitor, which will advise or kind of guide our treatment to be the end point of treatment. Once that is achieved, we know that we can then stop or either maintain this at this level. So if suppose you stop the gonadotropins and the patient is not yet ready for retrieval, then you may have a maintenance dose so that the testosterone is maintained around the level of 600. In the particular group of men with Klinefelters, the outcomes of using anastrozole first have been shown to be beneficial, and in such men you may use anastrozole before you actually use gonadotropins in these patients. So the non-responders, or the group where so the response that we see is basically in terms of testosterone rising to desired levels. And if we don't find that desired response in men that you've used the anastrozole or the aromatase inhibitors in, is the group that will move in with HCG with or without clomiphene. Thank you so much for your kind attention.
And I have one question. I would like to know that what is your protocol? Like how many sperms if you get and you do freeze the sample? Like if there are 3, 4, 5 sperms, then also will you keep that or freeze that sample or go for TISA or something? So what's your protocol?
Ma'am, I think I leave that judgment to the fertility expert and the embryologist in terms of whether they would like to have more of a sample. But my experience has been that when there are very few sperms to freeze, we always want more, because even with the newer techniques of sperm preservation, whether you're using or newer ones, but you still find survival rates less than 60%. So
I think that question can be answered by Ram also. He's going to take the next year. Embryologist Ram.
Madam, sometimes, the situation is there. On surgical retrieval, the sperms are very less in number. And, or the person, you find that the testes are very small and FSH is very high, and the patient is not willing, the biopsies have been done earlier, which showed that there is a sort of a hypospermatogenesis, and you are just getting 1 or 2 sperms per ejaculate. So I had tried this also in some of my patients. You take the unfertilized egg of any patient, and you remove the cytoplasm, so you have an empty zona now. Okay. Now in that empty zona, you inject the sperms along with the sperm freezing media.
Okay.
So, one medical officer came, the medical specialist. They wanted their own child, and every time he would come and he will, the whole ejaculate will have 1 or 2 sperms, motile sperms. So I would take those sperms and put it into the empty zona and freeze the empty zona, because single sperm freezing otherwise is very difficult. But once it is in a egg shell, so it cannot be lost during freezing. And then retrieval, once I had about 10 to 12 sperms, good motile sperms. Then I stimulated the lady and I took out those sperms from the empty zona, and they were blessed with the child. So when we have a very few sperms, this is one way we can, store the sperm.
What about vitrification device? If you compare these two technologies,
Which one?
Vitrification device for single sperm freezing.
No, that is there. But the thing is, this is cheap, because in an IVF lab you will always have some, eggs which are not fertilized, or they are GB. You're going to throw them again. To just aspirate out the zona, cytoplasm from inside, and keep those empty zona, and inject the sperms into that along with the sperm freezing media. So that is a possibility. I have done it before. I have one question for Dr. Vineet, a very nice lecture. Now, when we talk about, the testosterone estrogen ratio, so there is a doubt always in the mind of gynecologist. I want you to clear it. Which testosterone you are talking about, the total or the free?
No, it's always the total testosterone. We don't use the free testosterone is a calculated testosterone. We don't measure the free testosterone. There is a calculator available online on which you can do it if you have the SHBG levels available. And there are particular conditions where you would look at free testosterone calculation. When we mention TE ratio for a standard this thing, it only and only means total testosterone. We should only measure the total testosterone by a morning sample, since there is a day variation, a diurnal variation that you have with it. It's preferably, nowadays we recommend a fasting one, though it's not mandatory, but it's preferred because then they make sure that they do it in the morning.
So both estrogen and testosterone to be taken together on the same day.
Why would you pick separate times? It would make sense to do it together.
It should be done on the same day.
Yes.
Estrogen as well as the testosterone, and that's a total testosterone level to be compared with the estrogen. This is, I wanted to carry, the audience this message home, because sometimes you get the testosterone report by some other center. You may have a total testosterone as well as free testosterone level given. So then the gynecologist gets confused. Should I compare the testosterone total or the free testosterone vis-a-vis estrogen?
Right, sir.
Dr. Vineet, I also have a question. So you said that there are studies which say that in cases of NOA, if you give HCG and HMG, those combinations, then it may turn out to be better. But and you said that testosterone levels less than 400 is the criteria where we can, kind of select our patients. But if suppose FSH and LH, these are very high, the gonadotropin levels are very high, like suppose if it is 50, 60. So then also, do you think that these hormones are going to make a difference in these patients?
So the problem is that if you don't do it, your neighbor will do it, and you will, need to justify it. The evidence is not there, which is why even in my last slide, you saw it there. I've clearly mentioned in eugonadotropic, which means where LH and FSH, which is within the normal range, there is evidence of any change in that group. There is no guideline which shows evidence in men where there is a hypergonadotropic status. Having said that, do I use it? Yes, I've used it. If the LH alone is low and the FSH is high, then I'm more inclined to use it if the testosterone is low. But I've sometimes used it in couples where the man or they're not going to be going in for their retrieval for the next 3 months, or we've done some additional treatment and we're going to wait for 3 months, and I may use it. The evidence does not exist. In such cases, what and how much to use will be very individualized. So you may tend to use oral therapy only. You have very little evidence there. So then it also matters as to how much you are going to make them spend for treatment where there is no evidence.
And one more question: what is the importance of inhibin and AMH levels in males?
Yeah, I didn't discuss that because this is still it's still very, very early. But so we are doing more additional tests in all men that come to us. That is 17-hydroxyprogesterone, NFLB, and AMH. So 17-hydroxyprogesterone is said to represent the intratesticular testosterone. And so when you give treatment, you may measure, and levels above 1 are usually considered good, levels above 1.5 are considered normal, and you may monitor treatment. So if you consider that
Your voice is little breaking. Voice is little breaking.
Sorry, the connectivity may have changed. Is it better now?
Better, yes.
Yeah, otherwise I'll switch off the video.
No, it is better now.
Okay. So if the total testosterone, and it said it may not be an accurate measure of peripheral or intratesticular testosterone levels because they are the actual ones that control spermatogenesis. 17-hydroxyprogesterone is said to be a better predictor, and there is some evidence there. Similarly, inhibin B is dependent on FSH, and it actually moves inversely, absolutely opposite as in the direction of FSH. So the higher inhibin is a better indicator of possibility of spermatogenesis within the testes. And usually levels above 150 are considered to indicate a good chance that spermatogenesis may happen. And levels which are below 50 almost certainly tell us, and we're kind of agreeing with that, that when levels are below 50, we're almost certain that we won't find sperms when we attempt sperm retrieval techniques. AMH is another similar test, and there's recent evidence coming forward with AMH where levels below 4 are considered to be favorable and levels above 4 are considered to be unfavorable in men. I didn't put these slides up because evidence is very limited. And before I talk on such a wide forum and people start having any decisions based on them, I would recommend that if you do them, please have very distinct here, that is that they are not currently recommended for testing or decision making. You can only use them presently to assist your opinion and possibly have for more information with that. So if you've done all the other tests and you're already in a dilemma and your inhibin B is below 15, that you probably counsel them more in terms of a donor rather than telling them that they have a better chance with a microteasing procedure.
Right. Thank you. Dr. Yuktee.
Hi, Dr. Vineet. Wonderful lecture. So I just want to know one little thing. You were talking about in the hypo cases, we usually have used HCG. So where are you and how do you decide to use HMG instead?
No, instead to start.
You're adding on.
No, not adding on. We'll add in all patients. So if you look at guidelines for hypo, the treatment is both, which means you can start them concurrently or start with a gap of 6 weeks. And treatment is with both, because one will initiate and maintain the spermatogenesis. But the thing that most don't know about is when will you start with HMG first or give FSH before you give FSH. And there is a group where certainly cell maturation is not complete, where the testicular volume is less than 4 ml to begin with. And if that's an untreated patient, which means a patient who's not previously received any therapy, then you first want to have certainly cell maturation and then start HCG. Otherwise, you're going to stop the certainly cell maturation there itself and you won't have more.
All right. Right.
Dr. Sharda Jain, ma'am, we would want to have your expert comments. Dr. Sharda, ma'am, is there?
In fact, no, I just wished, sir, your lecture was great, but people like us got confused. We had an idea that in hypo, you give HCG and, when the testosterone levels are adequate, you add FSH. But you added third dimensions that you start with the anastrozole and then,
Not anastrozole, ma'am. Not anastrozole. Anastrozole came in for the empirical therapy and those with Klinefelters.
That's only for chemotherapy. Okay.
We've put in the fact that you are reversing the trend of using FSH before you would use LH. And that's for a very particular group of patients. The idea to bring forward is that we must be aware that, what is being served. Then we would have to go back into a little bit of our early genesis of how the genitals develop, what is mini puberty, when does the LH surge, and then. So not discussing. But we must be aware that there's a group where we can start.
Sir, another thing is, we wish to know that, people like us are sitting in Delhi, but, people who are in a two-tier city, where all such kind of facilities for treatment of hypo is available?
I think HCG and HMG is available everywhere across the. My only concern probably would be the quality of how they are maintained in terms of their cold chain. But otherwise, availability, I think, is available everywhere.
I think these small points are of great help to all of us as IVF practitioners, and we discuss less of male fertility. So I think we should have, ma'am, more on males also discussion, and Dr. Brigadier Sharma is always there to guide us. So thank you so much for a vibrant talk, and thank you for making it very, very simple. I think prescription writing is going to become a little better from our side now. Thanks for joining. Ma'am, can we move on to the next talk now?
Thank you so much.
Please, please.
Thank you, sir.
Thank you, Dr. Vineet. Thank you, dear chairpersons.
Thank
A word of
you.
caution, word of caution for everybody. Male infertility should be left to the experts in a male infertility. The people have no idea, should not be touching them.
And an examination from a urologist is always a must whenever there is a case of male fertility. So
I think
thank you.
examination part can be done by andrologist or any surgeons who's associated with you. Because to get hold of a urologist every time for an male infertility is going to be difficult. Sir, what do you have to say, Brigadier Sharma?
I agree with you, but the most of the time, I find the patient referred by a urologist, and he himself has not examined the testes. That is because I do not know. Because infertility is possibly, unless it's Dr. Vineet, for a urologist, infertility is something they just see the report and they write the treatment and send it. And when you take the history and then you realize that, this fellow has got different problem. So that is also there. Yes. In case we find any abnormality in the semen examination, at least at that particular point of moment, we must ask andrologist or a urologist to examine physically. And sometimes even when the reports are normal, a proper history is also very important. About the consummation of marriage and other guineas and all this. That is another big issue nowadays. Unexplained infertility. That is, it is not unexplained infertility, it is non-consummation of the marriage. So that is another issue nowadays which is increasing. I think Dr. Vineet will also agree with me.
Absolutely, sir.
Excellent talk, Dr. Vineet. Just wanted to clarify that for calculating the testosterone is to estrogen ratio, I've been using it going online and calculating that ratio, but what is the simplest formula by which we can calculate this ratio?
No, for the TE ratio, you don't require any online support. You take total testosterone and you divide by the estradiol levels, and you have that ratio there. So the measure that they will do will be in different nanogram per deciliter and picogram per deciliter, but the ratio is based on the direct calculation of the ratio. So if, let's say, you have a testosterone of 300 and a estradiol of 40, you know that the ratio is reversed because it's not 1:1.
Okay, because at times the units are different. So you mean
you
to
just
say
have to
that
be
these...
careful.
Okay.
You just have to be careful about the units, because usually you want them to be in nanogram per deciliter and picogram per deciliter, because that simplifies it.
Okay. And just one more clarification. Suppose the FSH and LH levels are very high, which means it's a testicular failure. So I think that question was already raised by Dr. Sunita or someone. So in those conditions, should we be giving? Because as it is, it's a case of testicular failure. So these giving...
no guidelines available for this. So if you were to ask, is there any evidence to support the use of any medical therapy for men that have hypergonadotropic hypogonadism? There is not. However, in men with Klinefelters, where the study was done, they did use, that's probably amongst the only studies. So there is some very weak evidence there, maybe one or two anecdotal studies, which have shown the evidence of using medical therapy, which is why for short terms, I may use them if the total testosterone is low and the LH is also on the lower side, not particularly high. Specifically, beneficial below 10. Evidence is extremely weak.
Because I think that would still be contradictory, because we have to keep that very cautiously in our mind. I would still be skeptical.
You are fair absolutely not to use it, because evidence for hypogonadism doesn't exist.
Yeah. Okay, thank you so much. Excellent talk.
Thank you.